Welcome, folks. This is part two. Welcome to Bio 202. Again, my name is Dr. Ben Pundit. Okay, so we're going to continue on talking about the cardiovascular disease or cardiovascular section. Okay, we already talked about the heart. Just a quick recap. We talked about the different parts of the heart, the structure, anatomy of the heart. We start to go into physiology, looking at the different node, SA node, AV node, um, AV bundle of his, and then Purkinje fibers. And then we talk about the cardiac cycle, the sound of the heart, the phonocardiogram. We also talk about the EKG, what that looks like, and different parts of EKG, P wave, QRS complex, and the T wave, and also the isovolumic contraction, isovolumic relaxation, and the quiescent period. So we already covered all of that. Okay. Next, we're going to talk about the terms of the heart, different terms that you need to be aware of for the heart. Okay, these terms come in very handy, very important when we're looking at these terms. Okay, so the first one is called the stroke volume. Okay, the stroke volume. Uh, okay, we're gonna look at the stroke volume. What is the stroke volume? Let's see. The stroke volume, again, is the amount of blood. Again, we only care about the left ventricle. We don't care about the other side of the ventricle because the right ventricle only go to the lungs, right? They only pump blood to the lungs. So we don't really focus so much on that right side of the heart, just to the lungs. So we want to look at the left side of the heart and see how much blood is on the left side of the heart. So this is the left ventricle. So when we talk about stroke volume, it's the amount of blood that pumped out by the left ventricle with each contraction. So what I want you to think of is the water bottle like this. Okay, let's say I have water up here to the water bottle, and every time I squeeze this out, again I have a cap on. If I release the cap, let go of the cap, and I squeeze the bottle, the amount of water that comes out one time, when I squeeze it one time, the amount of water that comes out from the water bottle is called the stroke volume. The amount of water, amount of blood that actually comes out of your left ventricle, again, left ventricle, okay, is that amount of blood that came out of the left ventricle. That's pretty much a stroke volume. Okay, so keep that in mind. So next one is called the cardiac output. Cardiac output is stroke volume times the heart rate. And again, that is not a definition, that's an equation to the cardiac output. Cardiac output define the definition or define as the amount of blood that actually pump out of your left ventricle in 1 minute. Okay, how much blood can your left ventricle pump out in 1 minute? Okay, how much blood did your left ventricle pump out in 1 minute? So basically, you use the stroke volume, right? That's the stroke volume. How much blood, the amount of blood that could pump out in one time when it contracts one time, multiplied by the heart rate. The heart rate usually measured as how many beats per minute. Okay, beats per minute. Okay, so this is the amount of blood per one beat. So technically, if you want to do a math, so this is the volume for one beat. Okay, one beat of your heart, and the heart rate multiplied by the heart rate. The heart rate is the how many beat that you have per 1 minute. Okay, per 1 minute. So what you have left, the beat cancel each other out. So what you have is your volume per that 1 minute. Okay, per that 1 minute. So that's what the stroke volume is. That's what the cardiac output is. Cardiac output is the amount of blood that your heart pump out in 1 minute. And as it turns out, your cardiac output normally is between 4.5 to 5 liters of blood. 4.5 to 5 liters of blood, and most of us here actually have about 5 liters of blood in your whole body. Okay, 5 liters of blood. So in 1 minute, technically speaking, you kind of circulate that whole 5 liters in your body. Your heart just pump that 5 liters around your body. Okay, so that's how fast your blood actually circulate every minute. Already go through your whole entire body. Okay. EDV and ESV. EDV referring to the end diastolic volume. Okay, end diastolic volume. To make the concept really easy to remember, okay, to really easy to conceptualize. So EDV is the amount of blood that you have when it's full, when it's right before you contract. So end diastolic at the end of relaxation. Okay, it's the volume. That's what EDV stands for. End diastolic volume. It's at the end of your heart relaxation. When your heart is relaxing, it's not contracting, it's just relaxing. At the end of that, what is the volume? Okay. So another word would be, the volume right before your heart contracts. Before it contracts, right before your heart contracts, that's the how much blood do you have in the heart in the left ventricle before it contracts. That's EDV. Okay, so again, the amount of blood that you have before it contracts, we call that EDV. EDV. Okay, and ESV, let's say you contract. When you contract, you pump out this much blood. Okay, you pump out this much blood out. Okay, this much blood. We already talked about what is the volume that your heart pumps out every time it contracts. We call that stroke volume. So this is the stroke volume. It's the amount of blood that your heart actually pumps out every time. What's left on the bottom is called ESV and systolic volume. Okay, and systolic volume. So that's the amount of blood that you have left inside. Let's say if I squeeze out all the as much as I can with this water bottle, the amount of water that's left inside that I cannot squeeze out, that's called the ESV. Okay, ESV. So think of it. EDV is the whole thing. This EDV is the whole thing. Stroke volume is what we pumped out. What's left, what's out. What's left on the bottom of the heart is ESV. Okay, ESV. So you put an E on top in front. So of the stroke volume, you have ESV at the bottom. E at the end and bottom. Okay, so one way to remember. So again, when it's full, we call it uh, end diastolic volume. When it's full, completely full, the top part is the stroke volume. The bottom part is the ESV. The one that's left inside your heart is ASV. The way we calculate the ejection fraction, this is something you really need to know because this is a huge term that you need to know. Okay. What is ejection fraction? Okay. The formula for ejection fraction is this. This is the formula. This is not how we define it. Again, that's not the definition. Okay. How we define it as a percentage. It's the percentage of the amount of blood that being ejected out of your heart. Okay, it's the percentage of the amount of blood that's being ejected out of your heart. This is kind of give you a glimpse of how efficient your heart actually is, how much efficiency does going on with your heart. Okay, so and this is the marker that many cardiologists actually use to look at your heart. The marker that your cardiologists actually use to definitely look at your heart, how well your heart is doing. If your ejection fraction is low, that means your heart is giving up. It's like throwing a towel. Like, I'm done. Uh, if your ejection fraction is high, that means you are actually doing really well. You're good. You're healthy. Okay. What is this supposed to mean? Okay, just gonna give you a little example. Okay, so let's say I started off with 100. If I have a 100, I'll put it a little number, make it easier to see. So 100, let's say I start with 100. Again, this is arbitrary number. Don't saying this is an EDV number. Your EDV is actually a little different, but this is an arbitrary number, make it a little easier to see and calculate. Okay, so EDV is 100. Let's say I pump out 55. Okay, what would be my ESV? Okay, so this number I have to be able to add with this number equals to 100, right? So ESV must be 40, must be 45. Okay, because 55 plus 45 equals to 100. Okay, so if I want to know the percentage of the amount that I pumped out, if I want to know the percentage of this, I would use 55 divided by the total number of the amount of blood. Let's say you took a test, you got 55 right, you got 45 wrong. What is your percentage of that 100 question test? How do you do that? You take 55, which is number you got correct, divided by the total number of the test, right? The question. So same thing, you take 55 because that's the amount of blood that you pumped out. You want to calculate that amount. What is the percentage of that amount? 55 going out. Therefore, we put 55 over a total number, which is 100. And the answer, what is the percentage? The percentage is at 55%. Okay, 55%. And in fact, that is the normal ejection rate, ejection fraction. Okay, that's the normal ejection fraction is at 55%. So your heart, your left ventricle, normally speaking, pump out about 55% or above. Okay. If you are healthy, you really fit, your ejection fraction will be in the 80s, 70, and 80s. Um, if you're not so fit, so, kind of not really exercise a lot, your ejection fraction will closer to like 60 or 65 or at 55. Okay. So that's mean, what does that mean? That's mean there's 45% of blood that's always sitting in your left ventricle, always. Okay, that's a minimum amount of blood that's actually there in your left ventricle at all time. You have 45%, or some you might have less, like 20 or 30%, but you always have some blood actually inside your left ventricle at any given time. Okay. Uh, when people have a heart failure, when we talk about heart failure, and this is again when the cardiologists actually look at this number really deeply, if you have a heart failure with reduced ejection fraction, now we call it HF, with reduced R, reduced EF. Okay, if you have the reduced EF, meaning that your EF is below 55 or 50, that means your heart is not doing too well. Your heart is not shabby. It's not doing, it's just giving up. It's just like, I'm done. I'm not doing this anymore. I give up this job. Okay. So that means your heart is slowing down. Then you're about to, you're one or two heart attack away from your heart stopping. So um, this shows a lot. This shows a lot about how efficient your heart actually is. Okay, so slowly know this term. The ejection fraction is the term referring to the percentage of the amount of blood being pumped out. Amount of blood being pumped out. Okay, of blood being contracted, being pumped out. Okay, or how efficient your heart is. Yeah, efficient your left ventricle is, technically speaking, because we only focus on left ventricle. So how efficient your left ventricle actually is. Okay, so please make a note of that. So again, we talk about the stroke volume um, of the heart. So athletes, when we talk about athletes, people who play lots of sport, okay, their stroke volume usually goes bigger. Okay, their stroke volume is increased because they are very efficient. They so exercise so much, so many times, so their heart is very efficient, so they pump out more blood. So when they pump out more blood, the stroke volume goes up. Okay, your stroke volume goes up. Then if their stroke volume goes up, normally their heart rate tends to go down. If you look at athletes, they don't need to beat so many times during that 1 minute because they already pump out enough blood each time that they're pumping out blood, right? So you think of it that way. Like if you are so efficient, if you are already pump out a lot of blood, you don't need to send out. You don't need to pump as many times. You only pump instead of 80 time or 100 time, you only pump 60 time. Or some people, a runner could actually have only 40 beats per minute because their heart is so efficient that they don't need to pump out a lot of time. Okay. Contrastly, this is what you're going to see in a lot of patients who actually have hypertension, high blood pressure, congestive heart failure, CHF, congestive heart failure, uh, coronary artery disease, where you have blocks inside your heart, blockage inside your heart. The stroke volume, because of these folks, the heart working way too much over time, the heart is kind of weak, so therefore the stroke volume goes down. When the stroke volume goes down, now the heart rate has to compensate by going up, right? So this is when you see these folks coming into your office, their heart rate is 110, their heart rate is 120, and we are talking about they just sitting and doing nothing. They're at 120. Some people might be seeing at 140. Okay, those are not good numbers. Those are bad numbers because your heart is pumping way too many times. Imagine you are 140 trying to squeeze your hand 140 times in 1 minute. See how tiring that is. Okay, how tiring that is. So your heart is working way too hard, way too hard. You want to slow it down. You want to make sure your heart actually is efficient. Okay. Another two term you need to know for your tests are these. Okay. Preload. Preload. This term here is the same as EDV. EDV. What is EDV? Remember the bottle, right? This is the amount of blood that actually inside your ventricle when it's full, okay? When it's full, right? That's the EDV, this amount of blood right before it contracts, when at the end of relaxation, right before it actually contracts, amount of blood that you have before you contract, okay? That's EDV. Same thing with preload. What does that mean? If you have a congestive heart failure, if you have hypertension, meaning that normally your EDV, your heart is so efficient, you might be able to get rid of the blood in more blood. Therefore, your EDV is in a normal range. But when your EDV increases, this means your heart is getting weaker. Your heart can pump out as much. When it can pump out as much, you actually have more blood inside your left ventricle. The more blood that you actually add on to it, like this much blood that you add on to your EDV, or it could be all the way to the brim, you add this much blood to your EDV, you're gonna, that's really a sign that your heart is not doing too well. Your heart is literally have a hard time pumping out blood each time because now you have more blood left inside your heart, and this is one of the things that will cause your heart to become bigger. We call it cardiohypertrophy, cardiomegaly as well. Your heart become bigger, not good. Okay. Afterload is the amount of pressure. Okay, this is the resistant or the pressure that being pushed back to the aortic valve. Okay, the pressure that pushed back to the aortic valve. This is what I showed you earlier, last video. Okay, this is the aortic valve. This is the ascending aorta. This is the pressure that being pushing back, and that pressure is called afterload. Okay, that pressure is called that resistance of pressure is called afterload. Afterload is the pressure that being pushed back to the aortic valve. If that pressure increases, okay, that pressure increases, that means you have harder time. Your heart has to work harder to push that door open, to push that aortic valve open. In the example I use in the cardiac cycle, imagine you have one person, right, one person pushing that door, but imagine there's two, three, four people pushing on that door. Your heart has to overcome that pressure by pushing, make it stronger to be able to push out that door open. Okay, and we see this with people who have hypertension, people who have vasoconstriction. So when the blood vessel constrict, the pressure inside your blood, when you have blood pressure, your blood pressure goes up. That's your afterload also goes up. If you do this long enough, your heart gonna be very, very tiring because your blood pressure high all the time. Then your heart has to work harder to pump out that blood. Okay, so let's go to everyone who have that condition, who have high blood pressure, because we want to lower it down because it's actually taxing onto your heart, causing your heart to become really tired and give out longer. We talk about isovolumic relaxations already. Okay, couple of things you need to be aware of for EKG, or ECG. Okay, one of the condition is called the myocardial infarction, which is heart attack, MI, heart attack. There are two type of MI, two type of heart attack. One is called STEMI, ST elevation MI, which is myocardial infarction. That's non-ST elevation MI. What is ST? If you remember from the graph, P, Q, R, S, T. So S is here and then T is here. So the space, the ST referring to the segment of the graph between S to a T, if this S and T is elevated, elevated means it goes up, just like in this picture here, okay, form little R, you could see right here. It would form this little R. This is called the transmural MI. Okay, form that little R, transmural MI. When you see non-ST elevation, this means that the ST is depressed. Okay, just think of it like you have a finger pressing on right here. This is my little finger here, pressing on into the ST segment. You're going to have a depression right here. This is called the non-STEMI MI or subendocardial MI. What's the difference between the two? Transmural MI affects two or more layers of your heart, meaning that it affects the endocardium and myocardium or epicardium. So it could affect all three layers of your heart, whereas the non-STEMI is only affects the endocardium and a little bit of myocardium, just a tad bit. So this in general is not as severe. This is more severe and this is more common as well, the ST elevations. Okay. So what would this be if you look at this right here? Okay. Um, this right here, what is this? Notice the one on the bottom. If you couldn't see, I'll make it bigger. Here we go. Make it bigger. Notice the bottom here. This lead right here. You could see. Would this be STEMI or non-STEMI? See how it being pressed down? Okay, being pressed down like right there and there. Okay, so this is non-STEMI. So therefore, this is what type of MI? This is a subendocardial MI. Okay, subendocardial. Only one layer endocardium or a little bit of myocardium, just a tad bit. Okay, how about this one? How about this one right here? So therefore, this is, yep. So this is the STEMI, which is ST elevated MI. Therefore, this is transmural, right? Transmural. That means it's more than one layer. Okay, more than one layer. It definitely goes into your myocardium or much, much more. Very good. Good job, folks. Okay. So we talk about all of those cardiac cycle, right? Talk about all of those cardiac cycles. So now we're gonna look at the blood vessel system. What blood vessel system? So we talk about in the lab we talk about the aorta. Aorta is the big, huge arteries, right? Aorta is the biggest one, and as you go from aorta, it's kind of break up into smaller ones. We call that arteries. Even smaller one would be arterioles, and then capillaries where the gas exchange and nutrients exchange happen. And then you go back to the heart through the venules, which is a small veins, tiny little veins, and you have veins, and then a big vein is called vena cava. Okay, the pressure in the heart, the biggest one is aorta is has the highest pressure, the greatest amount of pressure, and then the least amount of pressure is vena cava. Vena cava has the least amount of pressure. This is why we don't draw blood from you on your arteries. We always draw on the vein because it has the least amount of pressure. If we were to draw blood from your arteries, first of all, you're going to see a fountain of love coming out of your arm because then you're going to see these pulsated um, blood coming out of your arm. And second, if we put a tube into the artery, that tube will become a weapon, will become a bullet because the pressure is so great. That tube will shoot back at the phlebotomist that drawing your blood because your artery has a higher pressure, has a great pressure. It's gonna shoot that bottle back, that tube back automatically. Okay, so this is why we always draw it on your veins. Okay, on your veins. So the purpose of the artery branching is basically to create more perfusion, so cover a lot more area, right? A lot more tissue, and then decrease the pressure as well. As I mentioned, you want to bring down the pressure, okay, and uh, help with the solid and the fluid movements, and we'll talk about that when we get to hematology in your blood. Okay. Again, it goes from heart to aortas to arteries to arterioles, capillary, venules, veins, and vena cava. That's how usually it goes. Okay, there are three layers of your heart, your blood vessel wall that you need to know for your test. The first one is called tunica externa, which is on the outside. This has a connective tissue. You have the tunica media, which is the smooth muscle. This is how your artery actually contract, your aorta and your artery actually pulsating. They actually contract to move the blood along the way. And then the tunica interna, which is the inside, this is the smooth level inside that make things nice and smooth, that makes your blood nice and smooth. It has this little chemical called prostacyclin to kind of prevent any clotting, to keep your blood vessel nice and fluid, along with nitric oxide. We'll talk about that when we talk about your blood vessel next time. Okay. You learn this in the lab as well. This is blood pressure. You have systolic and diastolic. Systolic is when your ventricles are contracted, and diastolic is when your ventricles are relaxed. Okay, that's the pressure that we measure on your blood pressure cuff, um, to see how much the systolic, how much the pressure when your ventricle actually contract, and then when the pressure is actually relaxed. This is how we calculate the pulse pressure. Pulse pressure is the systolic minus the diastolic. So the higher number minus the lower number. You do need to know the map, the mean arterial pressure, and how to calculate them for your test. Okay, mean arterial pressure. This is basically the average uh, arterial pressure in your cardiac cycle. Um, Nowadays in real life in the hospital clinics, most people use the nurse, like we call it nurse Betty when I went through the school. Basically it's a machine actually that measure your blood pressure, your heart rate, and your pulse ox, and also it measure calculate your map for you as well, the mean arterial pressure. Okay. um, the problem, just gonna give you the little perspective. What we don't want is the number of your systolic and diastolic is further apart. If your systolic and diastolic is really further apart, you have a problem. Your heart is not efficient. Somehow your heart, the pressure in your heart is not balancing. You're gonna see a lot of problem. You're gonna see a lot of symptoms. But whereas it's close enough, then your pressure is kind of equal throughout. That means you don't have that a lot of variation in different places of your body. That means your blood could get to where it's supposed to go directly. When the pressure is so different, big gap, then you might see a drop of pressure at certain part of your body, and that's when you might see, like, feel tired, dizziness, or other symptoms as well. Okay. Couple of things you should know: there are thoroughfare channel versus the capillary sphincter. Inside the capillaries, inside your capillary, you have a straight channel. The straight channel is, I'll trying to run it with this color. Maybe I'll use a different color. Um, I'll use a highlighter. Okay, and I'll use a different color as well. Okay, it's in yellow. Good. Okay, so the thoroughfare channel, so this guy here, thoroughfare, is basically a straight through. It's the direct freeway that goes straight through from the from the arterioles to the venules. Okay, again, straight through, no turns, just go straight through. Okay, that's the thoroughfare channel. Thoroughfare channel. And then you have these, use green. Okay, you have these sphincter, pre-capillary sphincter right here. These white capillary sphincter. These are, just think of it like irrigation gates. Okay, irrigation gates. So these gates kind of rotating in terms of uh, which part they allow the blood to go. So this gate kind of works automatically. So sometimes the gate close kind of force the blood to come this way. Let's say this gate right here close, it forced the blood to come this way instead. Okay, maybe these two gate closest together, and they force the blood to come here to kind of go through this area, and then, a few seconds later, these gates open and these gate close instead, to force the blood going to this side. So what that does is actually kind of management of your blood more efficiently, so you don't have to keep the gate open all the time. When you keep the gate open all the time, the pressure becomes lower, and you can't really transport and transfer anything. So by open and close the gate, you always have certain part that you're sending the blood to, and that makes sure that part really gets the water that it needs to kind of gets the nutrient oxygen that it needs, before you could go on to the other part. So there's always a quarter of it always open at any given time, meaning that they kind of manage in quarters. So you have a quarter of this that's working area, and then the quarter of this area, the quarter of this area, the quarter of that area. So it kind of rotate between the four quarters all the time. Okay, so so keep that in mind. So your blood vessels are really your capillaries are very smart that way, kind of making sure you have different type of circulations and pressure throughout. Okay, the type of capillaries. There are several three types of capillary that you need to know for your test. So make a little sign mark here that you need to know this for sure on your test. First one is called the continuous. Continuous. Usually this is everywhere. Most of your tissue is continuous, everywhere in your body. Continuous. Meaning that you just have a little tiny crack like that, these little cracks. This is where the you exchange the gases, all the small gases, oxygen, CO2, nutrients could go leak out on these little cracks, basically. Okay, that's the common type, the most common type. Most of your body tends to have that type. The other type is called the fenestrated. Fenestrated is only usually in your kidney and your small intestine. Remember the location. That's where I'm going to test you on your exam. Is location of where these actually are. Okay, the location where these are. So fenestrated, it's going to be in your kidney and your small intestine. What are fenestrated? Fenestrated are these little tiny holes everywhere. You could see in these holes. Okay, this is allow the a little bit bigger molecules than these little cracks you see on the top. Okay, these intercellular junction, tight junction. So these little tiny cracks, it allows more stuff to go out than those little cracks. So a little bit smaller particles. You cannot let anything big out yet. Okay, anything big? No. So your red blood cells doesn't go out. Your many of your proteins don't go. Your white blood cells do not go out. So anything that's smaller than those goes out. Okay, like your nutrients, like your sodium, potassium, all those would go out these little tiny holes. Okay, and last one is called the sinusoid. Sinusoid is mean huge. It's the huge hole. It doesn't have a picture here, but imagine you have a big huge hole like this. Okay, big huge hole, and this is in your liver, your bone marrow, and spleen. Okay, so all of these need to deliver your blood. Need to detox your blood. Need to deliver your red blood cells, white blood cells. So therefore, they need a big hole to kind of fit those red blood cells, white blood cells and your platelet to actually go out. So therefore, you have a huge, extra huge hole for it to go out. Okay, for it to go to leave. Okay. So three, how your capillary actually exchange the blood. We'll talk more about that in the next chapter, but just know that it has to do with different pressure. Okay, it actually have different pressure going through these fenestrations and different types of holes. The usually you use diffusion, filtration, reabsorption. We're going to talk more about that in hematology. Okay. Um, so not to worry. Okay, diffusion usually caused by the gases exchange, going from your red blood cells going into into the cells. You actually have all of these diffusion with large particles. Transcytosis, basically you transport as a vesicles. Okay, transport it as a vesicle, like going through like these little droplets of water, transported. Uh, Okay, simple diffusion is just kind of seep it in, right? Diffusion just kind of going in from higher to lower concentration, whereas transcytosis, you take out the whole, taking the whole goblet, protein, hormones going all the way in. Okay, the one that you should know for this test is right here. This term, okay, you have these forces that being pushed in and pushed out of your blood vessels. Okay, you should know these terms for your test. So put a star here. Definitely needs to know these terms. You have the hydrostatic pressure. Okay, hydrostatic pressure. Hydrostatic. right here is mean pushing in. Okay, the amount of blood that being pushed in into the blood vessel. That's the hydrostatic pressure. The osmotic pressure, or colloid osmotic pressure, is the pressure that's being pushing out. Okay, uh, osmotic pressure. I'm sorry, osmotic pressure is also pressure is pushing in. Okay, pushing in as well. You have the tissue hydrostatic pressure. Okay, and then blood hydrostatic pressure as well. Okay, and I'm gonna show you that shortly. Okay, like these. Okay, so this is how we exchange blood, uh, exchange nutrients in your capillaries. Um, you have the hydrostatic pressure. Hydrostatic pressure, you have two pressure here. Okay, first of all, this hydrostatic pressure is the blood hydrostatic pressure. You have a tissue hydrostatic pressure, also pushing the stuff content from your tissue, from your cell, into the blood. uh, we won't talk about that. We'll talk about these pressure that pushing out. Okay, hydro is water, right? Hydrostatic is the pressure of water being pushing out. Okay, outside. On the arterial end is at 32 millimeter of mercury. On the venial side of N, it's only 12. So the pressure actually dropped from 32 to 12. Okay. And then you have the osmotic pressure. It's a constant pressure that actually push stuff in. Constant pressure that push stuff in. So think of osmotic, osmo suck it in, hydrostatic, you hydraulic, you push it out. Okay, you use hydraulics to pushing things up and out. So you push it out. So that's the hydrostatic pressure. The osmotic pressure is at 25 millimeter of mercury throughout. Therefore, on the arterial side, you have 32 pushing out, 25 pushing in. The net result is you're going to push out. Whereas on the venous end, you have 25 pushing out, but 12, I'm sorry, 25 pushing in, but 12 pushing out. Therefore, you're going to push that stuff in. So, what are the stuff pushing out? You're pushing out your oxygen, right? Your oxygen and your nutrients that you're delivering to the cells. And then what you're pushing in, waste product and water, and also um, CO2. You're pushing the CO2 back into the cell. Okay, so that's the kind of gist of what the differences between the uh, oncotic pressure, osmotic pressure, and the hydrostatic pressure. What the osmotic pressure and hydrostatic pressure are referring to. Another term you should know is called the oncotic pressure. Oncotic pressure is the pressure of the solute. Okay, the more solute you have, the less pressure of the water, right? So so oncotic is referring to solute. Okay, you have solute. So let's say if I put tons of solute, okay, like this one has a lot of solute. Therefore, I have a higher oncotic pressure. If when I have a higher oncotic pressure, I don't have a lot of water. The space in the between these circles, you have less space. Therefore, you have less hydrostatic pressure, right? Pressure of water. Oppositely, if I actually have the same vessel, okay, if I have, okay, only one oncotic pressure, right? Your oncotic pressure on this side is going to go lower because you only have one solute, unless you have three on this side, okay? And then the hydrostatic pressure, since I have tons of water here, there's tons of space, therefore I have a higher hydrostatic pressure. So the hydrostatic pressure is always the opposite to the oncotic pressure. Always. Okay, always the opposite. Because hydrostatic is referring to water, oncotic is referring to the amount of stuff that inside. So your sugar, let's say you how much your sugar, let's say you put 1 teaspoon of sugar in your coffee, you have a very low oncotic pressure. But let's say you dump in 10 teaspoon of sugar into your coffee, that means you're going to have a higher oncotic pressure but lower hydrostatic pressure. Okay, so people who have like dehydration and diabetes insipidus tend to have that, And people who have hypertension, diabetes, they tend to have a lower oncotic pressure and higher hydrostatic pressure, like the one on the right. Okay. Again, the purpose of capillaries to exchange gases in your lungs, in your tissues, your kidney, liver, spleen, stomach, everywhere. So exchange the gas, absorb nutrients, deliver nutrients, all of that stuff. A big one to remember for your test, your quiz also asks you this question as well. Okay, uh, ways that how your body return the veins, how the blood inside your veins return to your heart. The veins, unlike the arteries, arteries actually have the muscle in the tunica media that actually pumps the blood back to your heart. The vein doesn't have that muscle. Therefore, what does it have to do? It relies on other muscle. Okay, it relies on other muscle in your body. When you move your muscle, you actually pumping blood back to your heart. You're pumping that veins blood back to your heart. So skeletal muscle pumps the limb to actually help when you move your hand, move your legs. You're gonna live longer because you're gonna have healthier heart. You're gonna pump that blood back to your heart. Okay. The veins also have valves to prevent the backflow of your heart. Okay. Also, gravities help drain the blood from your head and your neck down to your chest. Okay, veins has very little pressure, very small pressure, and that pressure is not enough to actually pump blood to the back, but does some. If it's close enough, you could might be able to get it, but when you talk about down in your legs, that's not enough pressure to push that back to your heart. So it rely on other things like your muscles. Also, it's usually next to the arteries, and then when the artery pumps, it using that pulsation, helping the vein actually pumps blood back to your heart as well. Uh, you also have thoracic pump, okay, that actually help force the blood from your abdominal area, uh, increase the force to go back up to your heart. Yeah, so different mechanism to help regulate those. Okay, so the next one is the blood pressure and flow. How your blood pressure actually flow. There's different ways how your brain actually control your blood pressure. First is called the local control. Local control is basically, as it sounds, is regulation at that very specific tissue. If there's a loss of CO2 or loss of perfusion, and if your body, your tissue need more blood, it actually will vasodilate to actually help brings blood to that region, to that part of your body. Okay, or if you have too much waste, you want to remove the waste, then you might have a vasodilation to bring blood in to kind of remove those wastes. You also have the vasoactive chemicals that actually cause your blood vessel to expand and contracts. Okay, like your serotonin, your histamine, your bradykinin, prostaglandin, all of those can control using chemicals to control blood vessels. Okay, um, there's other type of local control is called angiogenesis. Angiogenesis is basically uh, creating new blood vessels. These are uh, your 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 bodies know how to actually create more blood vessels. And one of the things that how tumor, because tumor is a cell that actually needs blood, needs nutrient, needs oxygen, just like any cell in your body. The tumor cells are very clever by releasing hormones, releasing chemicals that actually fool your blood vessels, saying, "Hey, you need to supply blood to me. You need to create a new branch of blood to actually uh, to me, so I could actually grow." So eventually, that what happened, it released these little chemicals, and these chemicals actually tell your blood vessel to grow to the tumor, and then causing the tumor to actually becomes bigger. Okay, this is called angiogenesis. Angio is basically your blood vessels. Genesis is mean making, creating new blood vessels. Okay, um, you could also have something called reactive hyperemia. This is where you cut off the blood supply to those to those area, and then all of a sudden you're restoring it to those area. Okay, that's called reactive hyperemia. So let's say you press on down your finger, and then all of a sudden you release it, you're gonna see it actually going from turning white into red, uh, going from no blood supply to that area to now you have perfusion of the blood into that area. Reactive hyperemia. The second ways that how your body control the blood vessels is through the neural control. Neural control are these reflexes. You have reflexes in your blood vessels many places. One of the most important one to remember is there are baroreceptor. Your baroreceptor is the pressure receptor. There's one on your external carotid. Um, right here. So if you massage your external, I'm sorry, your internal carotid. If you massage your internal carotid, um, you're gonna fool your body thinking that that's your body have a higher blood pressure, and then your body will release hormone and chemicals trying to bring that down, to bring that chemicals, bring your blood pressure down. By pressing on it, you actually your body thinks is, oh, it's my blood pressure is up, my blood pressure is up, I need to bring it down, so therefore it's going down. So barrel means pressure, so it activates by detecting your the pressure inside the blood vessels. Okay. um, the proprioceptor referring to any activities or body position. It detects your body position and your activities. If you have tons of activities, body position, then it could detect and tell your body whether you need to increase the heart rate or blood pressure to that area. And last one is a chemoreceptor. The big one I want you to remember is the blood pH. Okay, because it detects blood pH, your CO2 and oxygen. So these are the three things that it detects. So when any of these actually goes down or goes up, your body, your blood pressure, your heart, your blood vessel will actually detects it and then trying to compensate it. Okay, it detects your blood pH, what your pH is. Your blood is actually at 7.35, 7.35. That's your pH of your blood. We'll talk more about that next section, your exam 2. We'll talk about that. Okay, so the blood pH is 7.35 to 45. CO2 is at 35 to 45. Okay, and oxygen should be at 98% or 90% and above oxygen. Okay, so it detects those. If any those are low, then your body will respond. Okay, again, barrel receptor, barrel reflex, as I mentioned before, when your blood pressure goes up, it automatically will bring it down. Okay, a chemoreceptor, again, it detecting these chemicals. So make sure you know these chemical for your test: pH, O2, and CO2. Okay, so these are the three chemicals that it actually detects in your blood vessels. Okay, so when you have hypoxic, usually if you have hypoxic, you're gonna have hypercapnia. That's when your body actually respond. Again, it doesn't really respond so much with the lack of oxygen unless it's really really low. It does respond faster with your change of your CO2 in your body. If your CO2 stay the same, this is what happened during COVID. Your CO2 stay the same, but your oxygen is low. It may not respond or detects anything. Okay, big concept, definitely big one to remember. Okay, this is a huge one to remember. This is called RAS. I'm gonna talk about this a little bit. Okay, about RAS. What is RAS is? Okay, um, so RAS. This is RAS here. Okay, RAS stand for renin angiotensin aldosterone system. Okay, you need to know this. It's going to be on your test. It's going to be on your test, and furthermore, in your medical career, you're going to see this over and over and over again. And this is a huge thing to remember for the people who actually have high blood pressure, people who actually have COVID. This is a pretty big, huge thing. Okay, so couple first thing that happened. So number one is here. Your you have a low blood pressure. Your body have a decrease in blood pressure. Your kidney actually detects it. Okay, your kidney detects it uh, in your glomerulus and your renal artery as well. Okay, um, it detects it. Once it detects it, it secrete a hormone called renin. Renin. So first R here. So question could be which organ release hormone renin? Okay, which organ release hormone renin? Is kidney release hormone renin? Right, kidney. Your kidney release hormone renin. Okay, so kidney release renin. Your liver normally always produce a hormone called angiotensinogen. Your liver normally produces a hormone called angiotensinogen. By itself, it doesn't do anything. By itself, it's just floating around in your blood vessels aimlessly. Okay, aimlessly, and just kind of wandering around. That's angiotensinogen just wandering around. When angiotensinogen meet with renin, they fell in love. They fell in love. Okay, they fell in love. They combined together. These two guys fell in love, see each other, combine together to make angiotensin 1. So now you have angiotensinogen, you have renin. When they combine, they become angiotensin 1. Okay? Angiotensin 1 then goes through your lungs through a angiotensin converting enzyme, also known as ACE. A C E. Okay, ACE. Okay, known as ACE. Okay, ACE. So ACE. So angiotensin converting enzyme. What is that converting? It's converting from angiotensin 1 to angiotensin 2. Okay, angiotensin 1 become angiotensin 2 because of ACE. Okay, angiotensin 2 does a couple of things. One, it actually causes your vasoconstriction. So it causes your blood vessels to constrict. Therefore, it increases the blood pressure. Second thing it does, it actually tells the adrenal cortex to release aldosterone. Aldosterone also tell your kidney to reabsorb water and sodium. Therefore, it increases the blood pressure as well. Okay. So this is how we increase your blood pressure in your body through renin binding with angiotensinogen to become angiotensin 1. That goes to your lungs, become angiotensin 2, and that angiotensin 2 cause your vasoconstriction and then cause your adrenal cortex to make aldosterone and therefore increase your blood pressure. Okay. The reason I want to point this out because we have a medication that lower your blood pressure by affecting this one right here. This is called as a medication called ACE inhibitor. ACE inhibitor always ends with pril, PRIL, lisinopril. That's ACE inhibitor. Okay, so what that does is stop the conversion of angiotensin 1 to angiotensin 2, hoping that it will lower your blood pressure. Okay, but ACE inhibitor has lots of side effects. People usually don't like it because there's tons and tons of side effects. But usually that's one of the first one that we prescribe to actually help lower your blood pressure. Okay, one of the first one we prescribe ACE inhibitor. Another one that we often prescribe is actually acting on this guy right here, the angiotensin 2 going to there to your adrenal cortex. Okay, uh, this is uh, this is the ARB. We call it ARB. ARB. ARB is a medication that actually blocks the angiotensin 2 to tell your adrenal cortex to secrete aldosterone. Uh, ARB is always end with sartan, SARTN, like losartan, one of the most common medication we give out. Losartan, what that does is actually absorb the angiotensin 2, and then therefore your adrenal cortex will not produce aldosterone, and therefore your blood pressure will not go up. Okay, so those are two medications that base on this little cycle, and our lovely little virus that we experienced a few years back called SARS-CoV-2, also known as COVID-19, affects this little guy right here. Uh, is okay. It affects the angiotensin converting enzyme. Okay, they actually affects the receptor of that in the lungs. When it affects the receptor of that, it actually creates not angiotensin 2, but rather create angiotensin 1-7. This is a deadly type of angiotensin because this type of angiotensin it actually causes clots everywhere in your body. So people who actually experience or had COVID might experience symptom of blockage and clot in the heart, in the liver, in the kidney, or even inside the brain. So people who have like long COVID might report feeling foggy, memory loss, having problem focusing, or even having heart issue, kidney issue, or liver issue. Okay, so that little enzyme, a little disease virus, cause a havoc in this little enzyme right here, receptor called ACE2 receptor. Okay, so that's why you should know this lovely system. What is RAS? Okay, because you're definitely going to be dealing with this for quite a number of years. Okay, we talk about aldosterone reabsorb. You should know this page here. What aldosterone does: reabsorb sodium. Water follows sodium, increase your blood pressure. ADH does the same thing. ANP and BNP promote the opposite. Get rid of the sodium, get rid of water, therefore blood pressure goes down. Epi and norepi, this is works on your alpha allergic and beta allergic receptors, causing your blood vessel to be constrict or dilate, depending on which one. Okay. Okay. Last portion of this section of the heart. Um, So first one we've been talking about is called CAD, coronary artery disease. This is where you have the atherosclerosis, the plaque kind of build up in your uh, artery, and especially right here in the heart. Okay, the arteries, the coronary arteries on your heart. As you learn your coronary arteries name, the left and the right coronary arteries. The one that really affects people the most is the AIA, anterior interventricular artery, or also known as widowmaker. Okay, so when you have clotting in there, okay, that can cause the blockage. That means you're not going to supply blood to that section of the heart, and that part of the heart actually will die, become hypoxic. Okay, risk factor are the age, high blood pressure, high cholesterol, okay, family history, smoking, obesity, all of that. And number one factor that you should be aware of is meat. Okay, meat. Anything you eat in terms of meat will actually cause this lovely disease. Okay, um, and this is not just coming from me, but from cardiologists around the world. Okay, if you want to get rid of CAD, you want to get rid of high cholesterol, you want to get rid of your blood pressure problem, stop eating meat. Okay, stop eating meat. Anything has a face, oh mom, stop eating. Okay, if you stop eating anything that has a face or a mom, you will reduce the chance of you getting heart disease or high blood pressure, okay, or cholesterol problem. Um, and I'm not saying that everyone has to be vegetarian or vegan, but if you have these diseases, by just changing your diet, it will save your life. Okay, if you have coronary artery disease, if you have heart attack before, if you know your family members or loved ones that have heart attack, uh, by just changing their diet, easily, simply changing their diet, it will help save their life. This is better than doing bypasses. We have doctors from Cleveland Clinic who been doing bypasses for years, and then all of a sudden he kind of like that didn't really work. Pretty much he just fixing the dam at the end. He then later found out if you change your diet, and then you could prevent all of this thing happening. Okay. Another disease that you should be aware of is called PAD, peripheral artery disease. Peripheral meaning on your arms and legs. These disease happen usually the arteries on your arms and legs. It block the blood to go down onto your arms or your legs. This is where you cut the blood supply, and you could cause damages on your extremities. So the way we notice is that you're gonna feel soreness on your palm, your heel. You're gonna have a weak pulse in your leg. You're gonna have bluish skin. That's mean you become cyanotic. Uh, and notice as well when you take a blood pressure on both sides of your arms. You might see a differences between the left and the right side, and that could, if there's a big huge gap between the two, that means you might could have a PAD as well, peripheral arterial disease. Okay, so beware of that. Another big one to remember for your test is this one called DVT, deep vein thrombosis. Deep vein thrombosis is a clot. You actually have a clot on your limb, on inside your vein. Okay, this is the great saphenous vein. Okay, you actually have a clot in your great saphenous veins usually. This is usually associated with a lack of activity, lack of movement. So let's say you're sitting in front of your computer for 12, 13, 14 hours. Some programmers do. Um, and some gamer might do that as well. If you're just sitting and doing nothing, not moving your legs at all for that long, or being traveling on the Trans-Pacific flight, going from the U.S. to Asian countries, you're sitting on a flight for 14, 17 hours, and without moving at all, you can get these called deep vein thrombosis. Uh, the blood could actually clot if you actually we something called stasis. If you actually your blood kind of static around and it start to create a pool of blood, when it start to circulate and pull up, that's when you actually start to build up a clot. Okay, the clot itself by itself doesn't hurt anything, but when that clot launch, okay, to your brain, to your lungs, it become pulmonary embolism. To your brain, you could become a stroke. So that's become a problem. But if it's on your leg, no worries. We could break it up on your legs. Um, you could have pain, you have tenderness usually, and you have swelling in the leg. Even people who stands a lot, you stand for a long, long period of time, can lead to this kind of things as well. Another one that huge is women who actually on birth control pill. If you're on birth control pills, what it does is actually dilates your veins. When it dilates your vein, you start to pull more blood. When you pull more blood, that's when you start to build up clots inside your blood vessels. So something to keep in mind. Women actually on birth control for years on end, 5, 6, 7 year, 10 years, you can develop DVT easily. And I've seen, in my practice, I've seen women in their 20s coming in had a stroke because of birth control pills. Um, their whole left side, the right side become droop and can't really move because of the birth control pills. Okay. Next one to talk about is called the mitral valve prolapse. Again, of all the valves, the one that troubled the most is the mitral valve, the bicuspid valve. Okay, on the left side of your heart, bicuspid, right? Usually it's asymptomatic. Okay, but you're gonna see when we talk about prolapse, meaning that you let the blood going back into the left atrium. Okay, going back, let the blood into the left atrium. And usually, when this happens for a long time, you can actually end up with heart infection or something called endocarditis, and you could have a bad valves as well. Okay, so prolapse meaning things going back, go against traffic, wrong way driving. So you're going back against the traffic. And in this case, in the prolapse, you're not going to see a lot of problem because you have the oxygenate blood, where you have lots of oxygen going back. This all it does is going to cause your heart to work more because you're going to have less blood going out. When you have less blood going out, your left ventricle will have to work harder to pump more blood to go out. Okay. And last one, I believe, it has to do with hypertension. This is high blood pressure. This is one of the common problems that we see in our society. Your blood pressure is high. For your test, you need to know the differences between the pre-hypertension stage 1 and stage 2. Okay, which one is which? I'm going to ask you on the test. I'm going to give you a sample, pretend patient blood pressure, and you need to tell me whether they are pre-hypertension, stage 1 or stage 2. Pre-hypertension is 80 to 89, stage 1 is 90 to 99, and stage 2 is 100 or above. Okay, so just look for the diastolic. Don't worry about the systolics. Your systolic goes up and down all the time. When you come in, see me, you are happy, then you or scared, either one, not nervous, your systolic goes up. Okay, your diastolic tend to stay the same regardless of your excitement. But what can change your hypertension is your diet. Okay, diet, diet in high fat. So any, especially animal fat. If you eat lots of animal fat, you definitely could get hypertension. Okay. Other problem like sleep apnea, thyroid conditions can actually contribute to as well. Okay. So that's a quick summary of this chapter. So if you have any question, please let me know. Thank you again for watching. Have a wonderful, wonderful, wonderful day and week. Take care.